disorder. And I'm also going to show you evidence that brain function may be more impaired in youth with bipolar disorder than in adults with bipolar disorder. So I'll start with that. Then I'll talk a little bit about children at risk for bipolar disorder. That's children who have bipolar disorder in their families, either a sibling or a parent, and talk about how we do research trying to eventually be able to determine which of these children will go on to develop the illness. And finally, I'll talk a bit about the controversy, which has been mostly in the United States, although it has reached into Europe to a certain extent. But in the United States, there's been a very big controversy about how to diagnose bipolar disorder in youth. And in particular, the question that people have been kind of debating is whether youth who have very, very severe and chronic irritability but don't have any clear manic episodes, should they be diagnosed with bipolar disorder? And I'm going to show you evidence that indicates that the answer to that question is no. And then I'm going to talk a bit about implications for treatment. So first, just to make the point that I'm sure many of you are very, very aware of, that bipolar disorder in children is a very severe and impairing illness. About almost all of these children need to be on medication. Many of them have been psychiatrically hospitalized. Many have suicidal ideation or have made attempts. And they're symptomatic most of the time, 60% of the time. So clearly this is we know that it can be a very severe illness in adults, but it tends to be a particularly severe illness in children. So obviously this is a really important area for us to continue to do research and to try to make some advances in terms of both treatment and prevention. So how do we study the brain in bipolar disorder? And why do we study the brain in bipolar disorder? Why is this an important thing to do? Well, if we can understand what's wrong in the brain, then we can identify targets for treatment. And while we would very, very much like to have effective treatments, what we'd like even more would be to be able to prevent the disease and keep people from ever getting the disease. So if we know what's going on in the brain that's wrong, this allows us to target some new treatment developments, novel treatments. And a very major advance in psychiatric research within the last 20 years is that we can now actually see the brain at work, the living brain at work. And we can do that using brain imaging, which allows us to study both brain function and structure in people with psychiatric illnesses. And I'm going to talk a bit later about how we do that and some of the things that we found. So in general, just sort of in broad brush strokes, how do we do this? How do we study brain function in bipolar disorder? So the first thing is we bring children or adults into our clinic here, and using computer tasks, we compare how people with bipolar disorder and healthy people react to emotional stimuli. So we have them play special kinds of games, and I'll be showing you what some of these are like. Now, when I say emotional stimuli, what do I mean? Well, one very common form of emotional stimuli that we use is emotional faces. Happy faces, sad faces, angry faces. And I'll show you examples of that. We also have children play games, computer games, where you can win or lose money. Now, these are special computer games that we've made where they're designed in such a way that we can measure how they're reacting, the children with bipolar disorder, at risk for bipolar disorder, with severe irritability, how they're reacting differently from healthy children. In terms of the emotional faces, it's important to remember that we humans are very, very social animals. The faces on the people around us are very important to us from an emotional perspective. We're hardwired in our brains to really be able to process this. So we do these tasks. We have people do these tasks in the clinic. And when we find tasks where people with bipolar disorder and healthy people differ in terms of how they do the task, then we have people perform that task while their brain is being scanned. And again, I'll show you some examples of that. Now, the first example I'm going to show you actually isn't brain scanning, but it uses another technique kind of like brain scanning. Well, another technique that, like brain scanning, helps us understand what's going on inside the brain, and that's eye tracking. But first, let me just show you this behavioral task. So you see a face, and it's a neutral face. Here's a neutral face, and the face gradually morphs into one of 6 emotions. And what you're asked to do is to say, when it's morphing, when you think you know what the emotion is, you say stop, you press a button that says stop, and then you guess which emotion it is. And what we look at is how much morph do you need to be able to get the correct emotion. And these are some data, and I'll walk you through this, but basically what these data show is that compared to healthy people, both children and adults with bipolar disorder need to have more emotion on the face in order to identify it. They need to see more morph. So here you've got in red bipolar children, blue healthy children, this pink is bipolar adults, and the yellow is healthy adults. And notice that both the healthy adults and the healthy children are higher on this graph than are the bipolar children or the bipolar adults. And that means that both bipolar children and bipolar adults do worse on this task. They need more morph to be able to identify what the emotion is. They're having a harder time identifying the emotion on the face. So we said, well, let's learn more about this. And one of the ways that you can learn more about this is by doing what's called eye tracking. And what you do is you have people in the clinic, like this woman here, put on this kind of fancy headgear. And what it does is it measures exactly what you're looking at when you look at a picture. And we did this study for 2 reasons. One is to try to understand more about exactly why might bipolar children be having more trouble identifying the face emotion, what's going on. The other thing is that we know a lot about the brain mechanisms that regulate eye movement. So this lets us begin to understand what's going on in the brain. That's been worked out very well. And I'm going to be talking more about the amygdala later. And we know a lot about the amygdala and where we look. I'll explain more about that later. But here, just to show you what we have the children do. They see a face like this, and the task is to identify the emotion on the face. So they see this face for 2 seconds, and then they see this screen for 3 seconds. And they have to press a button. They've got like a button box near their hand, and they press a button saying whether they thought that face was happy, angry, fearful, sad, or neutral. And here's the data, and what you can see, this is how accurate they were. And again, bipolar children are in red. They're always going to be in red. Healthy kids are going to always be in blue. And you can see the bipolar children are less accurate. So this is the same kind of finding as I just showed you before, but using a different task and a different group of kids. So now let's say, where do the children look when they're looking at that face? What part of the face do they look at? Do they look at the eyes, the nose, or the mouth? And what you see here is that the normal children are looking at the eyes more than are the bipolar children. And in fact, how much the bipolar children look at the eyes is related to how accurate they are on the task. So we can say that one of the reasons that the bipolar children are having difficulty identifying the emotion on the face is because they're not looking at the eyes. And this is what's called a heat map. And what you do is you average everything across all the people, and where it's red, the hotter colors, is where they're looking more. Where it's blue, they're looking less. So let's look at the healthy kids here. Notice here on the eyes this hot spot. There's also a hot spot on the nose, but notice this. They're looking at the eyes here. It's a hot spot, and it's pretty hot throughout. Now look at bipolar disorder. You see how they're missing this hot spot? So they're really not looking at the eyes as much, and they're not as accurate. Now this raises a number of issues. For example, if we trained kids with bipolar disorder to look at the eyes, would they get better? And would they have better ability to identify other people's emotions? And then would that in some way be related to their mood state? We don't know that, but, you know, this is kind of the thing I mean in terms of suggesting novel interventions, including interventions that don't involve medications. Now, I'm not saying this would replace medications, but as we well know, many of these children are on medications and are still struggling a lot, and one question is how can we make them even better? So this is very speculative, etc., but just to give you sort of a feel for how we think about these things. So both adults and children with bipolar disorder have difficulty identifying face emotions accurately. Children with bipolar disorder don't look at eyes as much as healthy children do. What's happening in the brain? I mean, that's the next question, right? What's happening in the brain of people with bipolar disorder when they look at emotional faces, and how does that differ from healthy people? And remember I mentioned about the amygdala, and I told you that people, or I mentioned that people with amygdala damage don't look at the eyes as much as healthy people. So what's the amygdala? Well, amygdala means almond in Greek, and it's an almond-shaped, and probably it's only a bit bigger than an almond. It's the structure in your brain, right, almost in the middle of your brain. And it's very important for detecting emotionally important stimuli in the environment. It's like if you were to see a snake, if you're walking in the woods and you see a snake, your amygdala would light up big time. It particularly lights up a lot when you see fear faces, because seeing somebody else afraid means, oh, there's something around here that I really need to pay attention to. It's like this early detection system in our brain. I got to pay attention here to something in the environment. That's the amygdala. Okay, so to look at the amygdala or any other brain structure, to understand how it might be working, we can use something called functional MRI. And here's a machine, sort of a functional MRI machine. Now, this is the person getting ready to go into the machine. This kind of stretcher thing that they're on would move inside, so that when they're inside and their brain is really being studied, you'd only be seeing their feet out here. But this gives you a sense of it. And how this works is it's a big magnet. This is really a big magnet in here. And this magnet can tell the difference between hemoglobin when it has oxygen on it and when it doesn't. And why that's important is when your brain works, when your neurons work, your brain cells work, they use oxygen. That's what they need. And so we can measure that, and that's how we can tell which parts of the brain are working. The important thing is that there are no needles, there's no radiation, there's no pain whatsoever. So we can do this with children. And in fact, when a child's inside the scanner, they can talk to us through a speaker, and we can talk to them through a microphone, and we can talk to them through speakers. And we have like pretend scanners that we have the children go into so that they can feel really comfortable, and et cetera, so forth, so that it can really be a comfortable experience for them. So one of the tasks that we did was we had children, and you'll see adults with bipolar disorder and healthy ones, go into the scanner, and they saw a series of neutral faces, fearful faces, and angry faces. And their task here was very, very simple. It was, is this a man or a woman? The reason we use that was it makes them look at the face, but this is what's called implicit emotion processing. What I was talking to you about before was explicit. We're explicitly asking what's the emotion. Here we're not asking exactly that, but we are saying look at the face, and we know that when people look at a face, even if you don't ask them to focus on the emotion, that they'll see it. So we just have them say, is this a man or a woman? And again, they've got a button box, so they push 1 for man, 2 for woman. So again, we want people to pay attention to the picture. And so we've got 4 groups here, children and adults with bipolar, children and adults who are healthy. HV means healthy volunteer. And this is where the amygdala is when you're looking at an fMRI image. The red are the amygdala, the left and right amygdala. So this is showing you amygdala activity. And again, you have bipolar youth in red here. You also got bipolar adults, healthy youth, healthy adults. Notice that the bipolar youth are high, and they're higher than all of the other groups. And this is when we collapse all those different emotions together. Remember, we had neutral, fearful, and angry. So we've collapsed all those emotions together, and we see that the bipolar youth have increased amygdala activity compared to everybody else. But if we look at it another way, and here we break it down by which emotion they're looking at, okay? Look here at the orange. That's fearful. And this is all bipolar people. So this is both bipolar adults and bipolar children. So notice that if you're looking at fearful faces, bipolar people, whether they're child or adult, have more amygdala activity than do healthy people. Okay? So what this tells us is that both adults and children with bipolar disorder have abnormal amygdala activity when they're viewing emotional faces. But in children with bipolar disorder, there's abnormal amygdala activity across emotions, no matter what emotion you're looking at. Whereas in adults, it's only abnormal when they're viewing fearful faces. And what this means is that brain function may be even more impaired in children with bipolar disorder than in adults with bipolar disorder. And this fits with what we see clinically because we know, I told you at the beginning, and we know that pediatric bipolar disorder tends to be a particularly severe form of bipolar disorder. So will brain function improve in children with bipolar disorder as they get older? Will they start looking more like the adults either because they've had medication which will help them or because they're developing other mechanisms? We don't honestly know that. And to figure that out, we have to scan children as they get older. We have to continue to scan them over and over, and that's with longitudinal studies. And in fact, we are doing that now. We are starting to do that now. So now let's talk a little bit about children at risk for bipolar disorder. And again, by at risk, I mean children who have a sibling or a parent with the illness. We know that bipolar disorder runs in families. If you look at the identical twin of a patient with bipolar disorder, 67 to 85% of them have bipolar disorder. So we know that there's a genetic component to it. We also know, this also tells us, since it's not 100%, that it's not all because of genes, but a lot of it has to do with genes. We know that the siblings and children of patients with bipolar disorder, in other words, these people at risk for bipolar disorder, are 10 times more likely to develop bipolar disorder than are youth who don't have a family history. But if you figure that out, remember that bipolar disorder in the population is, depending on how you define it and whether you're only sticking with bipolar 1 or you're doing all of bipolar spectrum, but let's say it's at most 3% of the population. So 10 times more likely is 30%. That means, and again, this might be generous, that means that 30% of youth with a family history of bipolar disorder, that's generous in terms of lots, that they might develop bipolar disorder. That means 70% of them won't. Most youth with a family history of bipolar disorder do not develop bipolar disorder. I think it's really important to emphasize that because I think there's a misconception that the reverse is true. Now here you've got diagnoses and offspring of adults with bipolar disorder. Now this is when they're only 12. So of course some of these children may go on to develop bipolar disorder. But notice anxiety disorder. Now again, we're at 25% here. About a quarter of them have anxiety disorder, a quarter of them may have ADHD. This is what's called oppositional defiant disorder, 8% major depression. So you do see lots of different illnesses in the offspring, and some of them are just perfectly healthy. But again, just to make the point that most children at risk for bipolar disorder do not develop the disease. So why is it important to study these children at risk? And again, I've told you what I mean by at risk. And it's what I go back to before. Ultimately, our aim is to prevent illness, not just to treat it. And if you study people who are already ill, you can't really separate out what causes an illness from the effects of the illness. So that's another reason. We want to be able to prevent it, and also this helps us really get at some of the causes of the illness, not just what happens to the brain after you're already ill with this. Okay, so you'll remember this task. You see a neutral face, and it gradually morphs into one of 6 emotions, and when you think you know what the emotion is, you stop it and you guess. And this is the same slide I showed you before, and here what we see is that the bipolar children and the bipolar adults are worse on this task than the healthy people, and they need more morph to be able to see the emotion. They have a harder time identifying the emotion. Well, here we've got the bipolar children again, and we've got the healthy children again. And in yellow here, these are healthy children at risk for bipolar disorder. So these are children who have a sibling or a parent with bipolar disorder, but they're healthy. Some of them have, at least from a mood disorder perspective, some of them have anxiety, some of them have ADHD, although if you take those kids out, it still shows it, even amongst the kids who don't have anything in terms of psychiatric illness. Notice that they look like the bipolar children. They differ from the healthy children. So the at-risk children also have some difficulty identifying face emotions. And that means if we can track back and understand what's going on in the brain, and we can follow this along and see, well, maybe it's the ones who have the most trouble with face emotions who are most likely to get bipolar disorder. But this is something we really need to study and understand and follow these children. And in fact, we did study these children, and so we put them into the scanner. We had them do a slightly different task. Here they were viewing fearful faces, and we were asking them, how afraid are you of this fearful face? And here you see the amygdala again. We were looking where in the brain might they have differences from healthy children. And this is the amount of activity in the amygdala. And notice that both the at-risk children and the bipolar children have more amygdala activity than the healthy children. So again, we're seeing something very similar in the children who don't even have the illness yet. And so we're continuing to study this. We're continuing to track what happens. Again, we're also continuing to see whether are the ones who have more amygdala activity the ones who develop the illness. So, like adults and children with bipolar disorder, children at risk for bipolar disorder have difficulty identifying face emotions accurately. Children at risk for bipolar disorder also have abnormal amygdala activity when they're viewing emotional faces. And as I said, the important thing is, can we eventually predict which at-risk children will develop bipolar disorder? Okay, so now let's talk a little bit about this controversy that we've had here in the United States about how to diagnose bipolar disorder in children. So the question that's come up is, does bipolar disorder look different in children than in adults? In adults, we know that bipolar disorder is characterized by episodes of mania and episodes of depression. I'm going to talk to you about what do we mean by an episode, but this is one of the core features, particularly episodes of mania are the core features of bipolar disorder. It's what distinguishes bipolar disorder from every other psychiatric illness. Now, a new idea started taking shape in the child psychiatry literature over the last decade or so. And that idea was that bipolar disorder in youth is not episodic, is not characterized by episodes of mania. And that instead, bipolar disorder in youth is characterized by severe, non-episodic, just sort of chronic day in, day out irritability and symptoms of ADHD. I'm going to explain this more as we go along, but that's what people basically started saying. Children with bipolar disorder don't have manic episodes the way that adults do. Instead, they are very, very irritable all of the time, and they have symptoms of ADHD. So this was the idea that people were putting out there. And the question is this correct? So first, to really understand this, let me explain more to you about what makes an episode. So these are the DSM-4 criteria for a manic episode, and there are really two things which make a manic episode. The first thing is a distinct period of elevated, expansive, irritable mood. So you have to have abnormal mood, okay, at least a week. For hypomania, it's at least 4 days. But the important thing is its distinct period. It has to be different from usual. It has to be different from your usual baseline. Okay, that's part of what makes it an episode. The other thing is there's all these symptoms that we think of as being part of mania. Grandiosity, decreased need for sleep, pressured speech, distractibility, etc. Those symptoms have to come on, they either have to start or they have to get a whole lot worse at the same time as you have this distinct period of abnormal mood. Okay? So it's an episode. In fact, you can't even diagnose mania in the DSM. You have to diagnose a manic episode. So it's an episode because it's distinctly different from baseline. The mood is distinctly different, and all of these other things also became different. They became worse, or they started at the same time as this mood change. It's a package deal, this episode. Now, if you say, like people were saying in the child psychiatry literature, you say, well, kids don't have episodes. They don't have manic episodes. Instead, what they have is very severe irritability, and you notice that there is irritability here as part of mania. But there's also here a lot of overlap with ADHD. You can have kids with ADHD, attention deficit hyperactivity disorder, who don't sleep, who don't need much sleep, who talk fast, who are distractible. That's part of the core feature of the illness. Who have racing thoughts, who seem agitated because they're very hyperactive, who are jumping around a lot. So you could see how you said, well, if I don't care about episodes and I'm going to sort of forget about the episode part, then you could take a child who's irritable all the time, has ADHD, and you could say this child is manic. And part of the reason it's important is because of treatment, and I'm going to talk about that in a minute. But the other reason that it's important is because ADHD is way, way, way more common than our true manic episodes in children. It's a very common psychiatric illness in children, and it turns out that many children with ADHD get quite irritable. So if you redefine bipolar disorder, as you will, in this way, many more children will end up being called bipolar disorder. And in fact, that's what has happened in America in the last decade. Now, we don't know exactly why it's happened, if this is why it's happened, but there's reason to believe that that might be so. And so, as I just said, in children, ADHD and irritability are much more common than episodes of mania. So how do you identify an episode? So here's an example. Let's say you have a child who gets up in front of the class and says, I'm smarter than the teacher. And the question is this grandiose thinking of a manic episode, or is this a child being oppositional? You know, so-called oppositional defiant disorder, ODD. Well, it depends, and it depends according to the criteria that I told you before. Is this usual for the child? Does the child tend to be an irritable kind of child all the time, and a child who kind of gets up and says things like this? You know, they've done it before. We see behavior like this not uncommonly. In that case, day in, day out. In that case, it's not really likely to be mania. On the other hand, if this is really unusual for the child, and at the same time that the child started doing this, he or she was having more difficulty sleeping, not being tired at all, having unusual amounts of energy, being unusually distractible for them, being talking much faster than usual for them, etc., so forth, then it might be mania. So you're always comparing the child to themselves. And in order for this to really be mania, it has to be different from the child's usual baseline. Now, irritability is very common in children and in psychiatric illness in children. And what I've done here is just listed all of the illnesses in the DSM-4 that have irritability as a part of them, as one of their diagnostic criteria. Those are the ones that are in white. The ones in yellow, it's in the text, is like associated, that you often see irritability in these kids. And as I mentioned, ADHD is one of them where it's associated. And one of the things which has happened with this whole controversy about bipolar disorder is that we've really come to realize that irritability is an extremely common but relatively understudied symptom. And we need to know much more about its clinical features, what happens over time, how to measure it in kids, what causes it, genes, environment, combination of genes and environment, what the brain mechanisms are, and of course, the treatment. So let's get back to our original question. Our original question is severe irritability in kids the same thing as bipolar disorder? Is severe irritability in kids how bipolar disorder presents in adults? Is severe irritability how bipolar disorder presents in children? Is severe irritability how bipolar disorder presents in children? So how would you answer that question? Well, one of the first things you want to do is you want to figure out what happens to children with severe irritability when they grow up. Do they develop bipolar disorder? If severe irritability in kids is a form of bipolar disorder, as they grow up, we should start seeing manic episodes, right? Otherwise, it's hard to say that this is bipolar disorder. You wouldn't say that. So we've done a couple of studies about that, and basically what we found is that irritability in youth predicts anxiety and unipolar depression in adulthood. Children who are irritable are at risk to grow up to have anxiety and unipolar depression, major depressive disorder in adulthood. And this is even if you follow them up through 20 years, up through age 33, which is beyond when the vast majority of people who are going to get bipolar disorder develop it. Irritability in youth does not predict bipolar disorder in adulthood. There really isn't evidence that an irritable child is at risk to grow up to have manic episodes. And we took extremely irritable children and studied them. Now, it's a relatively small sample, and we've only studied them for a couple of years. But, for example, these extremely irritable children that we study, these so-called severe mood dysregulated children, only 1 out of 84 developed a manic episode over 2 years. And actually now we've studied them for 4 years, and it's 200 kids, and it's like 2 children. So even if you take these very severely irritable children, they certainly are not developing manic episodes at any particularly rapid rate. Now, I will say that we don't know about the special case of children with a parent with bipolar disorder. So let's say you have a child whose parent has bipolar disorder and that child has very severe irritability. Does that mean this child is at particularly high risk for bipolar disorder? And we just don't know the answer to that question. We just haven't been able to study that yet. So the other thing you do to figure out whether this severe irritability is a form of bipolar disorder in kids is you look at the family history, because as we talked about, bipolar disorder runs in families, and children with bipolar disorder tend to have a family history of bipolar disorder. Well, it turns out that children with severe irritability are not particularly likely to have a family history of bipolar disorder. They don't tend to have very strong family histories of that. It's just like the regular population. So again, this says to us severe irritability in children probably is not a form of bipolar disorder. And we shouldn't be diagnosing severely irritable children as bipolar simply on the basis of their irritability. We shouldn't be giving them the diagnosis of bipolar disorder unless they have clear manic episodes. So what does it matter whether chronic irritability is a form of bipolar disorder? Well, it matters in terms of treatment. Diagnosis drives treatment. If severe irritability is a form of bipolar disorder, then you would treat with the medications that are first line for bipolar disorder, like antipsychotic medication and anticonvulsants. But if severe irritability is really ADHD, these kids do have ADHD also, plus anxiety or depression, and remember I've been telling you about why we might think that, then you would think about treating with stimulants for the ADHD and antidepressants, the so-called SRIs, the serotonergic reuptake inhibitors, for anxiety and depression, and possibly CBT, cognitive behavioral therapy for the anxiety. If you think these children with severe irritability are bipolar, though, you'd say, oh, I don't want to give them stimulants and SRIs because that'll make them manic, right? So it matters. Now, it's really important to say that we do not know if stimulants and SRIs will effectively treat irritability in children. We don't know. We are currently doing a trial of that here at the NIMH. But this is just the way you would think about it. And you would think, oh, well, this is really worth trying. Whereas if you think these kids are bipolar, you go right to the antipsychotic medications and you think, well, I wouldn't do stimulants and SRIs. So we currently are testing whether stimulants and SRIs work in children with very severe irritability. So in summary, bipolar disorder in children is very impairing. Children with bipolar disorder, adults with bipolar disorder, and children at risk for bipolar disorder all have difficulty identifying face emotions, and they all have abnormal amygdala activity. So we are finding some behaviors that seem to go along with bipolar disorder across development and also perhaps go along with some brain dysfunction. Severe irritability is not diagnostic of bipolar disorder. It's associated with depression and anxiety when children grow up. The more we learn about what's wrong in the brain of people with bipolar disorder, the better able we'll be to treat and prevent the illness. I want to thank you all for listening. I am going to be taking questions now. I want to especially extend a thanks to the children and parents who participate in our studies. They're very much our partners in all of this work, and our fondest wish is that we can do something to help advance the treatment of this illness. And that's just a shout out to all of them. I want to thank the International Bipolar Foundation for sponsoring this, and here you can see their website, www.internationalbipolarfoundation, that's all one word, .org/donate. And this is for our studies. We're recruiting children with bipolar disorder, these children with severe irritability, children at risk for bipolar disorder. We recruit children from all over the country. We pay expenses for people to travel here. We can tell you all about it if you just either call us on the phone or email us. And we'll be very happy to speak with you about it. Ashley, I think I can take questions now.
Yes, thank you so much. That was absolutely excellent, and we appreciate all of you joining us today. As Dr. Leibenluft had mentioned, without your support and donations, we cannot continue our webinars and lectures, so we greatly appreciate anything that you can contribute to us today. We will start by answering some questions, so feel free to type them into your control panel on the right-hand side of your screen. Thank you. Our first question is, I have a 6.5-year-old adopted boy whose birth parents were supposedly diagnosed as bipolar. What, if anything, can be done to reduce his chances of developing bipolar?
So that's a great question. I think that, first of all, we don't clearly have any data on that at this point. In other words, no one's done controlled trials that would really answer that question. Common sense would say that you would want to, and again, even in a child where, say, both parents had bipolar disorder, and honestly you don't know for sure whether or not they did, even in that case, most children will not develop bipolar disorder. So I think one important thing is that you should assume he's a normal child, okay? And not necessarily, you want to be vigilant, etc., but you don't want to overdo it. In terms of vigilance, I would say that if he starts exhibiting any sorts of any behaviors that are of concern to you, you could get a consultation, and even you could go talk to someone, you as the parent, and describe what you're seeing so that the child psychiatrist could, in most instances reassure you, or at least, work with you. The child may be showing some symptoms of something which isn't bipolar disorder, but may have some other symptoms. So I would have a low threshold for talking to somebody, but as I say, it could just be you talking to them. They're having a relatively regular kind of sleep-wake cycle insofar as that can be done. Of course, we don't want any of our children to be using or abusing substances, but that might be particularly important in this kind of setting. So it's things like that. It's really kind of general healthy things, and feeling free to talk to someone if you're having concerns, but really assume that the child is doing fine unless you really start seeing something different.
Thank you. This next question is from Terry. My son's school nurse noted that my son did not track his eyes well on a reading chart, losing his place and switching lines. She thought maybe he needed vision therapy, but it was not approved by IEP. Do you think this would be valuable to insist on?
Well, I don't think we have, I think that you should think about this from the perspective of his eyes and his vision. So from a psychiatric perspective, I wouldn't say that we know enough to say you would insist on it, but I would want to know from an ophthalmologist whether it's worth insisting. A pediatric ophthalmologist, or the first person actually I would go to would be the pediatrician. I think you should ask your pediatrician whether it's worth insisting on it and go from there.
Could you please speak to the incidents with skip generations, grandparents, aunts, uncles, etc.?
So those are what are called so-called second-degree relatives. First-degree relatives are siblings and parents. Second-degree relatives are aunts, uncles, and grandparents. And I can't offhand, honestly, quote you the data on that, and there's much less data on it. It is significantly lower. The risk, in other words, if you have a second-degree relative, what's the risk compared to if you have a first-degree relative? And the answer is clearly much lower. I'm having a bit of trouble dredging up a number in my mind, for which I apologize, but it is significantly lower.
Thank you. I have an 11-year-old adopted son. He has been in and out of hospitals. We just can't seem to get him the right help. How can we help? How can we get the help we need? We live in an area that just can't get him the right help.
Well, the first thing to do is to try to get a second opinion. I assume, it's going to be hard for me to give you specific advice, of course, without knowing the details. In general, what one does is ask your doctor to get a second opinion. One looks for a university medical school with a psychiatry department and the child psychiatry division. So maybe you live in an area which doesn't have good services, but maybe the nearest big city, which I agree might be far, it might be worth going just for a consultation with somebody there who can then help guide the physicians in your community. So I would say that that's, you can talk to your psychiatrist about that, saying, we really feel like we'd like to get some more information. Who's an expert that we can go get a consultation from? Is there somebody local? If not, where is there a medical school that has a good child psychiatry department? That's a good place to try to get a particularly sophisticated second opinion.
Thank you. Do you have any statistics on children with severe irritability that were treated as ADHD or with SSRIs being at a higher risk to develop bipolar disorder as an adult?
No, we don't. Now, one of the things that we don't have data that speak to that one way or the other. One of the things that we were very concerned about when we started this trial of stimulants and SRIs in children with severe irritability was, would they become manic in the here and now? Based on our clinical experience, we thought that that was not going to happen, but, based on the concerns that we talked about and the concerns in the community, we're certainly very vigilant about that. I will tell you that we are not seeing that. So cross-sectionally, in the here and now, the children are certainly able to tolerate this. That doesn't, I don't know yet whether or not it will make them better, but at least for now, it certainly is not making them bipolar. The whole issue of what happens in adulthood to children who are treated with psychiatric medications, what happens in adulthood if you treat the child with psychiatric medications is, of course, a huge issue. And that's something that we're very, very concerned about. What you have to realize is that these children that we're seeing are extremely impaired. I didn't mention this, but they're as impaired as the children that we study with bipolar disorder. Okay, so I showed you how impaired the children with bipolar disorder are. The children with severe irritability that we're enrolling in this trial are every bit as impaired, so they need something. And many of them come to us on these atypical antipsychotics. And the problem with the atypical antipsychotics is they have a lot of side effects in terms of weight gain and in terms of the metabolic side effects. And although it is certainly true that we don't know what treating them with stimulants and SRIs might do later in terms of adverse kinds of effects, we do know that they need treatment now, and we do know that in the here and now, the toxicity of the antipsychotics is greater than the toxicity, the side effects of the stimulants and the SRIs. But your question is an excellent one, and believe me, if we could figure out something that would treat these kids without medications, that is my fondest wish.
Thank you. Can you please explain what pressured speech is?
Yes, it's speaking so fast that you can't be interrupted. And I hope I didn't do too much of that while I was speaking. But it's speaking very, very fast.
Thank you. My son was diagnosed at 4 years old. He is now 19. Are there any studies for those over 18?
We do not study people over 18. There's an investigator here at the NIH named Carlos Zarate, Z-A-R-A-T-E. I'm sure you can find him on the web. Or if you contact us, we'll give you his contact information. They are doing studies in adults. Technically, your son is an adult. Once you pass 18, you're an adult.
Can you illustrate what a child's psychotic episode might look like versus a healthy child's imagination? I'm assuming.
Go on.
Sorry, I'm assuming there's a spectrum from mild to more severe. What would a more mild episode look like?
Well, that's a great question. And the whole issue of psychosis in children can be somewhat difficult. Somewhat difficult. What's exactly, what do you worry about versus not worry about? Because it certainly is very true that many children have unusual or report unusual kinds of experiences that you're concerned may be psychotic. It, of course, matters a lot what age you're talking about. That's one thing which matters, and it also matters what developmental level the child is at, because we know, some 10-year-olds, or I could pick any age, but let's just pick 10 to be perfectly arbitrary. Some 10-year-olds are much more mature than some other 10-year-olds. What you really need is you need a well-trained psychiatrist who's really going to spend time talking to the child, as well as talking to you, talking to the child about what the experiences are, and talking to you about what you've observed. Things that tend to make you think it is more psychosis is the child acts on it, the child really believes it, can't really distinguish fantasy from reality. Although, again, when I'm saying this, I'm having a hard time saying it, because if I was, talking to a 7-year-old or a 5-year-old, I'd have very different feelings than if I'm talking to a 10-year-old or a 12-year-old or a 15-year-old. If I was talking to a 10-year-old with developmental delay, that would be something different too. So but those are the kinds of things that we tend to look at, but it really requires very careful clinical assessment. Somebody's really got to talk with the child and talk with you.
Thank you. Our daughter has had a brain scan with Amen Clinic, which solidified that she has anxiety disorder and bipolar disorder. She is adopted, and her birth mom was a drug alcohol addict. She is now 16, and her whole life has been exhausting for us since she was 2. Should we continue to get scans every couple of years to see if her brain improves and if the severity decreases?
No. There is no way currently to diagnose psychiatric illnesses using brain imaging. And thank you for asking this question, because I realize that I was remiss in not saying this earlier. This is currently a research tool. You cannot make a diagnosis using brain scans now, at this point in time. The best way to make a diagnosis, the only way to make a diagnosis, is through careful evaluation and interviewing with a well-trained, knowledgeable person. In the future, we do hope that brain imaging will be a useful adjunct and, another useful tool to help make diagnoses, but it is not there now. It is not there now. And even when it is a helpful tool, it still is, it's not going to be, you just look at the brain scan and You're still going to need the careful assessment. This is only a research tool now. It does not have clinical use. And as I say, I regret actually not having said that sooner, so I really appreciate the question and the opportunity to clarify that.
Thank you. A couple questions from Valerie. Is it true that those with major depressive disorder as adults can cross over to bipolar disorder? And if there's no development of bipolar disorder, what happens to those with severe irritability in youth?
So what happens to, let me take the second one first. What happens to the children who are severely irritable in youth is when they grow up. Now, remember, we're only talking about the group and what happens on average. We can't say that this is what's going to happen to every individual child who has severe irritability. But we're saying if you take a whole group of them and you look at the statistics, one of the problems with research in general now is it's about groups, it's not about individuals. And one of the big pushes is to try to develop ways we can really predict a given individual. We can't do that right now. Severely irritable children as a group are more likely than healthy children to grow up to have depression or anxiety. So that's what tends to happen to them. But many of them can do perfectly well, and a few of them may go on to have other things, or some of them may go on to have other things. Certainly not many of them will become bipolar according to our data. If you have this major depression, can you go on to develop bipolar disorder? That was the first question, and the answer is yes. But if that's going to happen, it tends to happen before age 35 or so. Okay? It's rare to have a first manic episode later in life. It happens some, and it mostly happens if people have had very unusual strokes or something like that, or it can happen otherwise, but the vast majority of people who are going to develop bipolar disorder do it by age 35. And the study I showed you went through age 33. So it's unlikely that those children, now grown up to adults, those adults are going to ever get bipolar disorder.
Thank you. Will we be using MRIs to diagnose bipolar disorder, or will face interpreting be used?
That's a great question. I don't think that face interpretation itself is going to be used because it's probably not specific enough. You can see some of these problems in other illnesses, like, of course, forms of autism. You can see some of it. You know, we don't, ADHD, it's debated whether or not they have a similar kind of difficulty. Behavior is cruder than is the MRI. The MRI is more detailed. So I would say it's more likely that we'd be ultimately using the scans than we'd be using that particular behavior. Now, there may be other behaviors, or it may be that if we combine this behavior with some other behaviors that we have that I didn't talk about, you could have a battery of tests. It's possible, and that would be good because it would be nice not to have to put people through scans, not because they're unsafe, but, you know, they tend to be expensive. So I wouldn't rule out that we could do it by behavior at some point, but at this point, I would say it's more likely it would be the scans because those tend to be more specific. But all of that is still in the future, really still in the future.
Thank you. Can you review the symptoms of mania that you commonly see in children?
They're the same as in adults. So you see euphoria, elation. They're way, way happier than they should be. It's not just being silly. It's actually more protracted than that. And it is laughing a lot more. And you should see that change like for most of the day. It shouldn't be like you see it for, you know, half an hour when they're playing with their friends or really tired and they're getting goofy. It should be kind of for at least a few days, most of the day, that they're really unusual for them, either happy or irritable, but unusual for them. When they get grandiose, it's things like, I want to call up the president, I have some good ideas. Sleep is very important, and it's not just that they can't sleep, it's that they're not tired. So they stay up all night doing things, and then they're not tired. They're just rip-roaring ready to go. They've had very little sleep, and yet they're rip-roaring ready to go. They talk really, really fast. They can't concentrate on anything. Let's say it's somebody who likes to draw. They'll fill 20 notebooks, you know, in 2 days. So it's really a lot like it is with adults. I mean, they're not maxing out on their credit cards, but, you know, at least not the younger ones. But, you know, it's really pretty similar.
Thank you. The next question is, I lead a support group for adults. Almost everyone in the group has another relative with bipolar disorder. How can you say that most kids with a bipolar parent won't develop bipolar disorder? Are psychotropic drugs neuroprotective for developing bipolar?
First of all, when you say, you know, that you run a support group and nearly everyone has a relative with bipolar disorder, that doesn't mean that you wouldn't be seeing all of the people who have relatives who don't have. there's lots of people out there who have relatives with bipolar disorder who don't themselves have bipolar disorder, and they wouldn't be coming to your group, if you follow what I'm saying. So just because people with bipolar disorder tend to have relatives with bipolar disorder doesn't mean that everyone who has a relative with bipolar disorder develops it, and they wouldn't necessarily, the ones who are healthy aren't necessarily going to be coming to the group. And that's a lot about like what's called ascertainment bias. But people have looked at these studies. I mean, that is basically what the data show. The data show that most children with a parent with bipolar disorder don't develop it. Are these psychotropic drugs preventive against bipolar disorder? We don't know that. And certainly I would not suggest treating somebody to prevent bipolar disorder. Because we just don't know that that's, first of all, we can't predict well enough who will get it. And second of all, the drugs, of course, themselves have side effects and are relatively nonspecific. So at this particular point in time, all we can do is treat when people get symptoms, but we really don't treat based on their family history.
Can you explain the difference between hypomania and mania?
Sure. Hypomania, so part of it's the duration. What I talked about, the minimum duration, I said you have to have a distinct episode. For mania, that has to be at least a week long. For hypomania, it has to be at least 4 days long. The other difference is the degree of impairment. For mania, it has to be severe impairment or hospitalization. For hypomania, it has to be noticeable to others. So hypomania is a more mild form of mania, and that's defined according to how long it lasts and how severe it is. Hello?
Hi, is there a higher concern of personality disorder?
That's a very good question about whether there's higher rates of personality disorder in people with bipolar disorder. Is that what the question is, or is the question whether children with irritability go on to have personality disorder?
Yes, that is it.
It's the second one.
Yes.
Okay. According to, it hasn't been very well studied, but according to that study that we did, the answer is no. We were, to be perfectly honest, somewhat surprised, and they also did not tend to have higher rates of substance abuse, which also made us a little bit surprised. Now, that was only one data set, and it needs to be looked at more, but at least based on what we have now, I would say not necessarily.
Okay. You mentioned effects of symptoms from bipolar episodes in the children. What effects would you look for? Would it increase cycling and mood? Are you currently doing studies on this?
Say that question again.
You mentioned the effects of the symptoms of bipolar disorder episodes in the children. What effects would you look for? Would there be an increased cycling and mood? And are you currently doing studies in this?
Well, so what we look for, I'm going to interpret this question. I think what I'm being asked is, what symptoms do we look for when we diagnose bipolar disorder in children? And the symptoms we look for is we look for a history of a clear manic episode, so this distinct period of time when the child was different from usual that lasted at least, 4 days, and they were very hyper with all those criteria and also had an abnormal mood. And yes, we definitely are studying children with bipolar disorder. We're also studying the children who are very severely irritable and don't have the clear episodes of mania. So we're studying both of them and we're comparing them. And we're also, as I mentioned, studying children who have a family history.
Thank you. Can you teach bipolar disorder children how to better identify emotions and faces?
We haven't tried that yet. It's a great question, and we haven't tried that. People have tried it with autism, or on autism spectrum, and what they've found is you can teach the children to do it, but it's not clear how much it generalizes. So, in other words, you can get them to be better on the computer task, but it's not clear whether that actually makes them better at it in the real world.
Thank you. The new DSM is supposed to come out May. Do you think this will change anything?
It will change a few things. In terms of bipolar disorder, it will make more clear that there has to be a distinct episode. This is true in both adults and children. The criteria for a manic episode are exactly the same in adults and children, and it will stay that way in DSM-5. It'll just be more clear it has to be an episode. There also, in the DSM-5, is going to be a new diagnosis called DMDD, Disruptive Mood Dysregulation Disorder, and that will encompass this very, very severe irritability. Because these children didn't really have a good home diagnostically previously, so that's going to be a change in the DSM-5.
Thank you. The next question is, I have a 12-year-old son whose diagnosis has been all over the board, including anxiety, ADD, and bipolar disorder. The treatment producing the best and longest lasting positive impact was to do a blood workup and treat nutritional deficiencies through supplementation. What are your thoughts about treating bipolar children through supplementation?
Well, there's been some work on this, and the most of it being with the omega-3s. The data are somewhat mixed. I would say that there's not a clear signal that it works, but I would also say that there is some data that suggests that it might. I think it's sort of a little bit on the edge right now in terms of the omega-3s. The other supplements really haven't been tested that much.
Great. And I think we have time for two more questions. Is there a general rule of thumb that the meds for ADHD will exacerbate bipolar disorder?
That's a great question. There certainly is some possibility of that, that it could exacerbate it. It's unclear exactly how much and how often that happens, etc. But certainly if you truly do have true bipolar disorder with clear manic episodes, you wouldn't want to treat with stimulants unless, and this is important, they're also on some kind of mood stabilizer. If they're on some kind of mood stabilizer, there's at least one study which shows that if you have a child who's got both bipolar disorder and ADHD, and you treat the bipolar disorder with a mood stabilizer, then it's okay to also add a stimulant, and that will help their ADHD.
Thank you. And the last question is, my question has to do with the process of elimination type diagnosis. If there is no clear mania but severe irritability, and the child gets worse, more irritable to violent on stimulants and antidepressants, would they then be diagnosed with bipolar disorder?
That's a really great question, and it depends whether what they had was truly a manic episode or whether it's what's called activation. It's very, very common for kids to get kind of activated on stimulants or on antidepressants. But it's much less common to have that truly be a manic episode. So you really have to have a very careful assessment of that. And then, even in adults, there's a question of if someone has a manic episode on antidepressants, is that the same thing as really having bipolar disorder? So it's a complicated kind of situation, and you really need to have somebody very carefully assess exactly what the child looks like when they were on those medications.
Thank you, and thank you so much for joining us today. We apologize if we could not get to all of your questions, but feel free to email us. I will put my email in the chat box for all of you to send me an email if you have any further questions. And thank you again, Dr. Ellen Leibenluft. It was absolutely wonderful, and we appreciate all your time.
Well, and I really appreciate everyone's attention, and I really do appreciate the questions.
Thank you. Take care.
Thanks.
Bye-bye.
To all of you too. Bye.